So in the final section of Barrett's esophagus, we'll be studying about the treatment of esophagus. What are the different treatment modalities which can help a patient to get rid of Barrett's esophagus? And this will be studying about treatment of GERD. As GERD is the main culprit which ultimately causes Barrett's esophagus to occur, so how will we treat a patient with gastroesophageal reflux disease so that the patient ultimately does not end up with Barrett's esophagus? And then endoscopic surveillance for dysplasia. How can endoscopic surveillance help patient with Barrett's esophagus to not have a cancerous result? And then we'd be studying about the treatment of mucosal neoplasia. What is the ultimate treatment to get rid if the patient does occur with a neoplasia and cancerous culprits? So in the treatment of GERD, we'd start with the maintenance therapy with a proton pump inhibitor for patients with Barrett's esophagus. As you know, that proton pump inhibitor will help the patient to have a decrease in the production of the gastric acid. And as you all know, that the acid is one of the most important factor for carcinogenesis to occur and for the Barrett's metaplasia to occur. There are some researches that have been done, and they've said that long segment Barrett's esophagus might be resistant to proton pump inhibitors, and this usually occurs because of the reflux of the acid contents from the stomach, which causes a profound refluxitis, which causes the patient to be completely resistant from the proton pump inhibitors. Another treatment could be the fundoplication, which is more effective than any anti-secretory therapy or medication for preventing cancer, which is a surgical procedure which takes a part of the stomach cardia and wraps around the esophagus, which is called as fundoplication. But some data suggests that anti-reflux surgery should not be performed solely for the patients for cancer prevention. This is usually done only for the patient with gastroesophageal reflux disease, and it is unethical to perform such a grave surgery for patients to only prevent any sort of cancer to occur. Aspirin and NSAIDs. Aspirin and NSAIDs have a very potent effect. They protect against the esophageal adenocarcinoma. They protect the esophageal adenocarcinoma by inhibiting the COX-2 receptors, and then through the mechanism of independent COX-2 inhibition. It is usually also prescribed to patients with any sort of cardiovascular diseases or patients with cardiovascular risk factors. Aspirin has been given in 325 milligram daily with esomeprazole, which inhibits any sort of peptic ulcer or gastric ulcer to occur, and occurs by reducing the levels of prostaglandin E2 in the Barrett's esophagus. Endoscopic surveillance. Some of the researchers have recommended endoscopic surveillance for patients with Barrett's esophagus, but a few argue that endoscopic surveillance is not ethical because of the following reasons: that endoscopy can be expensive, and then this endoscopic surveillance, the use of the endoscopy can have a lot of risks, and then the third thing is that it has a very emotional and financial consequences because of the endoscopic procedure. And finally, they've said that there's no proof in relation to any sort of randomized controlled trial within the patients that it has any effect on the patient's survival of Barrett's esophagus. The American Gastroenterology Association and the American Society of Gastrointestinal Endoscopy and the American College of Physicians recommended endoscopic surveillance for patients with their esophagus only if they have multiple risk factors for esophageal adenocarcinoma. So what are the risk factors? The risk factors include chronic gastroesophageal reflux disease, if the patient is occurring from this. They've said that if the patient occurs from, if the patient is an older patient that, with the age 50 years or above, if the patient is a male patient, if the patient is from a white race, if the patient has hiatal hernia or an elevated body mass index, and then if the patient has an intra-abdominal body fat distribution, nocturnal reflex symptoms, and finally, if the patient smokes. So these are the risk factors that the associations, the societies have recommended endoscopic surveillance, that they might have the risk factors for the esophageal adenocarcinoma. Now we come to the treatment of mucosal neoplasia. What is the ultimate treatment to get rid of Barrett's esophagus or any sort of neoplasia that is occurring within the esophagus? There are two types of endoscopic treatments. One is the endoscopic ablative therapy. In this, we use heat, cold, or photochemical therapy. Cold in a way that we spray a cold carbon dioxide or nitrogen gas. And the second is the endoscopic mucosal resection, in which diathermic snare or an endoscopic knife is used. So these are the two most important endoscopic treatments that are being used. In the endoscopic ablative therapy, what happens is that the neoplasia, the area where the neoplasia has been occurred, the ablation goes deep, but it's not so deep that it causes any complication within the esophagus, such as any stricture or any hemorrhage. It doesn't cause any serious complication. And then the other thing, the negative part of the endoscopic ablative therapy is that after the therapy, we are not being provided with any specimen which helps us in diagnosing the extent of the neoplasia that has been occurred, or if we want to see the completeness of the ablation. So this is not provided with endoscopic ablative therapy. Whereas endoscopic mucosal resection, in this we are being provided with a specimen in the end, an esophageal specimen, through which we can realize that how much of the esophagus, how deep is the esophagus being resected, and is the esophagus completely free from the neoplasia. Endoscopic eradication therapy is called when these both therapies, the endoscopic ablative therapy and the endoscopic mucosal resection, is combined together. And this is usually used in patients for non-dysplastic Barrett's metaplasia. After having this endoscopic eradication therapy, patients are being prescribed with proton pump inhibitors to let the patient have a normal regrowth of the normal squamous epithelium of the esophagus. And then in the end, we have the esophagectomy. Esophagectomy is a very definitive but hazardous procedure. It causes a patient stay in the hospital for as long as 2 weeks, and it also causes a patient to have at least 30 to 50% risk of developing any of the serious complications such as pneumonia or myocardial infarction can occur. And ultimately, the patients might also develop one of the serious comorbidities, which is weight loss and dysphagia. So esophagectomy is the least option which are being decided for the Barrett's esophagus patients. Now, if we talk about endoscopic mucosal resection, this is a picture in which the endoscope is being transferred into the esophagus. This is the esophagus, this is the mucosal layer, muscular layer. At the tip of the esophagus, first of all, the dysplasia, the epithelium with the dysplasia, is being raised with the help of inserting fluid underneath the dysplastic epithelium. Saline is injected below the lesion, which causes the dysplastic epithelium to raise. And then a suction cap is being present over there, which causes this which causes the bump to be suctioned into the cap, which is present at the end of the endoscope. And then finally, a snare is placed over the lesion. A snare helps rejecting and resects the dysplastic epithelium which has been raised, and thus the esophagus is completely free from the neoplasia. So in this section, we have studied about the different treatment modalities for the Barrett's esophagus. The first is that we should treat gastroesophageal reflux disease, as Barrett's esophagus is a complication of gastroesophageal reflux disease. Thus, we have to treat the gastroesophageal reflux disease with the help of proton pump inhibitors or with the help of the surgical treatment, which is called as fundoplication, which ultimately prevents Barrett's esophagus from occurring. Other than that, aspirin and other NSAIDs have a very vital role in inhibiting any sort of Barrett's esophagus. And the ultimate treatment of the neoplasia are by two different techniques, which is called as the endoscopic techniques, and they help. The first one helps in ablating the esophagus with the help of heat, cold, and photochemical therapy, and the second is the esophageal resection therapy, which causes the resection of the part which is abnormal in the esophagus, and ultimately the esophagectomy, which is the least most used procedure for the treatment of Barrett's esophagus. That's all from this topic. Thank you for watching sqadia.com.